Hi, everyone. Thanks so much for joining us today for our podcast, No Stupid Questions. I'm Dr. Kim Bissell, the Southern Progress Endowed Professor in Magazine Journalism and the Associate Dean for Research in the College of Communication and Information Sciences, or CNIS, at the University of Alabama.
And I'm Dr. Annalisa Bellin, an Assistant Professor in the Department of Communication Studies, also at the University of Alabama, and we both work in the Institute for Communication and Information Research, or the ICIR, at UA.
Have you ever gone into a doctor's office and had questions that you wanted to ask, but didn't feel like you could ask? Or have you ever thought, I can't ask that, that's a stupid question? I have, far too many times. This communication, or lack thereof, is just one of the things our next guest studies: the communication between a doctor and patients, and how that communication can really influence the care you receive.
So I think you're right. I mean, I go into the doctor's office sometimes. I will take a notepad. I'm ready with questions. I'm ready to take notes. And then for whatever reason, I just don't ask. I don't take notes. I get nervous, start sweating, and I leave. And then I think later, I should have asked that. Or maybe like right before the doctor leaves, maybe I'm like, oh my gosh, can I ask this? And I feel weird. And so I wonder if healthcare providers that we see, is that part of their training to ask us if we have any questions or how to talk to us even? So our next guest, Heather, she not only studies communication between patients and healthcare providers, but she also does work in training healthcare providers in how to communicate with patients.
So we are really excited to talk with Heather today because she has almost all the answers to these types of questions that we have about communicating with healthcare providers. So we want to welcome Dr. Heather Carmack, an associate professor in communication studies who studies health communication research at CNIS at the University of Alabama. Welcome, Heather.
So Heather, first, can you give us an elevator pitch on your research?
Sure. So kind of short elevator pitch of the work that I do. I'm really interested in the way that both micro and macro communication practices help us to make sense of the health and healing experience. And so what that means is I'm interested in the relational micro as well as organizational macro practices because those inform each other. So it's not just you talking with your provider in an office. There's a lot of organizational factors that impact that. And the work that I do in medical errors and patient safety really kind of speaks to that beautiful intersection of relational and organizational, because what our providers can say to us about a medical error is going to be guided by hospital practices and policy and legislative rules. And as patients, we don't always think about that. And so the work that I do really tries to marry those two things together to understand the whole health and healing experience.
So that all sounds really amazing and interesting. If you had to come up with a headline for one of your most interesting findings, what would it be?
I really struggled with this one too. I had to combine it all together. And I guess the best headline I could come up with is that early and often communication training can save patients' lives. The work that I've done, especially with someone that I collaborate with, we did a study, and it has a couple different articles, but found that students, if they receive communication training about medical errors, can find ways to stop a medical error before it happens. So if we really have that training, I know that we can save lives.
Okay, I think that's a great headline. So if you see it as the title for this episode, don't be surprised. I think
save lives, right?
Exactly. So can you just tell us a little bit more about some of these findings in terms of medical errors and just elaborate a little bit on that?
Sure. So in the communication field, it's actually a very small, there's only 3 people who actively study medical errors as part of our research agenda. And 2 of us are here in the United States and another is in Europe. And so there's a lot of work to do. And the work that I've done tries to be fairly expansive. I mostly have focused my work on the after medical error event, which is disclosure and apology. And in that work, I really focused on, tying together those micro and macro communication practices about the role of organizational policy, the role and impact of institutional training and beliefs, of the medical field, and how that influences how providers disclose and apologize errors, how they make sense of the whole experience themselves. And then recently, we've been collecting data from the patient side about how patients are making sense of those experiences. And then I've also done some other work that explores how, we can train providers as they're, in their student role, right, as nursing students or in medical school or OTPT, whichever type of professional health you were in, right, how we can really train future providers to be better communicators, and then that can impact our ability to effectively communicate. And so the work that I've done really kind of spans those two. It's really hard to explore the communication that happens while a medical error is happening because you don't know when they're going to happen. So it's really hard to be present to witness something like that. But the work that I've done really focuses on those 2 communicative events, basically the before and the after, because we can't stop them from happening. Medical errors are going to happen because it's, medicine is practiced by humans and humans make errors, but we can be better communicators about it.
Wow. How much does it matter kind of, where you are in the country or even in multiple countries? How much does policy impact how people are trained or how people communicate within a medical setting?
Well, a lot of providers don't receive any training at all.
So little
starts. I mean, and that's again one of the reasons why I focus on both the micro and the macro is because, a lot of that starts from lack of training in the educational experience, right? So in your nursing programs or your medical schools, dentistry, they're not necessarily being taught. Now, I'm not saying that everybody doesn't get taught. Some places do teach, and some places do really well. Others just sort of leave providers to figure it out on their own. And then whatever they learn or don't learn, that becomes part of their institutional practice and memory. And then once they become fully fledged practicing providers, they enter into these organizational spaces that might have organizational policies that dictate what and how they can say that. And then depending on where you're located here in the United States, we have what are called healthcare benevolence laws in many states. And those actually do dictate legislatively what and how a provider can disclose and or apologize. And in some cases, they're very specific and they provide specific wording that you can use. So for example, in some states, you can't express sympathy. In other states, they actually say, what type of word you can use. And so all of that is impacting the communication that happens. And I don't know that, as patients, we don't see that side, right? We just see, the vulnerability of health. And then when a medical error happens to us, dealing with the aftermath of that. And patients often report, that they get frustrated because they, hospitals and providers aren't giving them information. And we don't always know it's because they can't, but we think it's because they don't want to. And that isn't really always true. And there is plenty of research that suggests this, and some of my research has found this as well, that patients, the monetary compensation is fine, but really they just want disclosure and apology. They just want to hear what happened, and they want to know that you're going to try to not have it happen again. So, disclosure and apology is a communication act. So the fact that the answer that patients want is a communication answer means that we have to be involved.
Well, I think it's fascinating what you said, that in some states, doctors aren't even allowed to express sympathy. That's not something that I think most patients or any of us would really even know. You just think that your doctor is being a little bit cold and abrupt,
Mm-hmm.
you know?
So when it comes to your research, how do you, I'm trying to think of how to ask this. How do you do you do any training along with the data collection of these medical students or nursing students as you're collecting the data?
Not previously, in part because in some cases I wasn't there to collect the data and that wasn't the involvement.
Mm-hmm.
But in other cases, it really has to do with what the clinic or the hospital is willing to have me do. So, like, as a researcher entering into those spaces, I'm always really thoughtful and cognizant of, what's my role and what would they like me to do? And I don't want to overstep that boundary because that could fracture that relationship with that clinic or that facility. And I don't want that to happen. So on some points, I haven't had as much of a chance. The pieces that I have done at one of the hospitals that I worked at was integrated into the curriculum after I left. So they are reading the work and talking about it.
Always a bonus.
It's a bonus,
Right.
which I find really flattering because, communication research isn't always valued by the medical and health communities. And the fact that gets incorporated at least says that facility values what we can bring to the table. I'm hoping to, now that I've actually just started, as in I was just there on Monday, started doing some communication training with residents at a clinic. And so I'm hoping that I'll be able to integrate that in, but I've only been there one time. So baby steps for that.
So I guess similarly, how as a researcher do you, how do you get into these clinics and other healthcare settings?
It takes a lot of work.
I can imagine. After hearing about what you do,
oddly enough, I mean, I've never had anyone, like, once I get a foot in the door, I've never had anyone say, no, we don't want you to be here because of the work that you do. But it's that getting your foot in the door into a healthcare facility is actually really challenging. And part of it is, figuring out who the right person to help you get the foot in the door is. And I've been really lucky that at the clinics and the mobile health clinics and the facilities that I've worked in, that I was able to identify who that really good gatekeeper was. I'll use my qualitative language here. My gatekeeper to get in. And part of that also, too, again, to use some more qualitative language, is identifying a really good sponsor, someone who is supportive of your work and who can really champion your work. And if you find a good sponsor, and the person's not like necessarily involved in any of the work that I'm doing, they're just there to be a cheerleader and excited for the work that I do. And so if I find a good sponsor and I figure out who the right gatekeeper is, that opens a lot of doors. And so that's usually where I start, is figuring out who it is. But it's also, when you're doing this type of work, you have to do kind of a game plan of assuming that it's going to take time. It can usually sometimes take, 5 or 6 months in order to go through all of the paperwork and all of the red tape that it takes to get into a facility. Because you sometimes need to go through, it's not a hiring process, but you might be declared sometimes like called a worker without compensation, or you need some kind of specialized role to be in the facility. And you just have to be really mindful of that and be thoughtful about how long it might take to get in.
So Heather, you're a professor in communication. You're doing work in sort of health practice. Do you have opportunities to collaborate with others? And if so, how does that all work for you?
I do. So I collaborate with people in communication, but I also collaborate with medical providers. And for example, I just had a call, was it yesterday? No, the days are bleeding together, so it's hard to remember. Yesterday with a connection that I've had for about a decade now, which is at Harvard Medical School and the family van that they run, which is a mobile health clinic. And we were just talking about a project that hopefully we might be able to get started. And so I'm able to, I think, kind of walk that line. But part of it is like when you're working with medical providers is you have to have medical providers who understand that communication brings something to the table.
Right.
And that's typically when I work outside of our discipline, when I'm working with like health and medical professionals, they're people who appreciate and understand what communication brings.
So one of the things that I really wanted to ask you about, and I'm not sure if you've done this work specifically, but one of the things that I think has really come to light in this global pandemic that we're in is this notion of health disparities and access to health providers. And one of the things that you talked about earlier was kind of the communication between the patient and the doctor. And what I'm wondering is, with certain populations or with certain individuals, they may, be sitting in front of a nurse practitioner or a doctor, and you just kind of take everything that's being said at face value because you don't know necessarily to ask questions. Can you just, and it can be sort of anecdotal or just based on what you've read or what you've done, can you talk a little bit about, health disparities and how it kind of looks in this arena that you study?
Sure. I have encountered health disparities with the work that I've done on mobile health clinics. I've worked on both rural and urban mobile health clinics. So you get to experience a wide variety of health disparities and see how, things like poverty manifest very differently depending on where you're located. And some of the things that I saw when it came to health disparities is, you mentioned the asking questions, but part of it is not necessarily knowing what questions to ask. And I think a lot of health disparity work that kind of, or I wouldn't label the work that I've done health disparities, but it's involved in that, really hinges on health literacy. And just that, depending on where you're located, that we haven't spent as much time as we should have, educating populations about health issues. And I don't mean, like health communication people or public health people going out into the community. That's the work they're doing. But, even at, say, like, the K through 12 level, we're not spending time talking about, that health literacy issue. So I have a friend who did some amazing work about food and food deserts in rural Appalachia. And her studies really involve children, and just being able to talk to them and understand, like what types of food they can and can't get access to impacts their eating choices, right? Or like she had them draw, what does it mean to be healthy and what does it mean to not be healthy? Like, what do those foods look like? And then talked about with them, how they are able to get access to that or not get access to that. And so some of those choices, they might know it, but they can't do it. Right? They just don't have access to that. And I think as communication scholars, there's a lot that we can bring to the table to help, create campaigns, help create materials that can help to educate. But that I think is even more important, the work that we can do can be used in advocacy efforts to bring money or education, right, to those. Because that's not necessarily work that we can do, but others can use our work to help advocate for those things.
Well, and I think, what you're hitting on is just so important and relevant. And what we often forget is just where we are right now in Tuscaloosa. You go 30, 45 minutes away and you find yourself in, a part of the state where you can't get to a medical provider, you can't get to a Publix, you can't get to anything without driving for 45 minutes, and I think looking at health in general through that lens is just really, really fascinating. It also is very, very sad, but, it's just fascinating to kind of step outside of our little bubble and look at it from that perspective.
That's one of the reasons why the work that I've done on mobile health clinics has been so impactful to me, because the whole point of a mobile health clinic is to try to address that access issue of, it's a 45, 50-minute drive to your local hospital or your local clinic. That's a long drive. And maybe you don't have a car, or maybe you don't have gas money. And
Right.
here's an opportunity to bring healthcare to you. It's such an empowering, like, alternative form of organizing that I wish we were doing more of. And they're expensive to run, and they usually are grant funded, so it's hard. But like, that's where I think our money could be going to help address that. And I know that we have a mobile health clinic here. I just learned about it. I saw a picture on the website, and I thought, we have a mobile health clinic.
What?
Really?
Yeah, that's how I found out about it. I mean, so there are just so many wonderful opportunities with that we can do, like alternative ways of organizing and thinking to try to address some of these issues.
Mm-hmm.
So kind of related, we know that one of the things that comes up, particularly with underrepresented populations, is trust, and trust of medical providers, and trust of researchers. So impact the work that you do, even with gatekeepers or getting into clinics or working directly with collecting data from patients.
So for me, I've been really lucky in that I have been able to get into facilities, and people have been very welcoming. Patients have been very welcoming, because they sort of understood the reason that I was there. But some of the things that I do, like when I enter into a space, especially if I'm going to be doing maybe an ethnography or at least some observations, is spending time doing those observations, but letting people get comfortable with me, understanding what I'm there for. And I think also breaking down a lot of the barriers that we have. And I'll do little things like the way that I dress will be to help break down those barriers. How I introduce myself will be to break down those barriers, so that eventually they'll get to trust me and see me as a person that they can talk to, that they're comfortable with me being in the presence. But I have been really lucky that the work that I've done, I've never been asked, like when I have done observations at clinics or in the mobile health clinic, and I'll be in the room when there's some kind of medical procedure done or talking about some really sensitive issues. And I'm lucky that I've never been asked to leave. Patients were always really comfortable with me being in there.
Wow.
And I think that's something that as researchers, one thing I know I tell my students, and it's coming out in your conversation, is you have to care about what you're researching. And that totally comes across to participants, to gatekeepers. And if you don't care, then you're gonna, I guess it's like animals and being scared, and they know you're scared. That trust level, I'm trying to think of how horses react to me, and it's not always good because I'm nervous around them. But,
well, I think part of that is too, right,
relevant.
that I really love what I study. And even like once I got out of graduate school, I sort of made this conscious decision that I was never going to pursue a study or a topic if I wasn't interested or passionate about it. Right. There are so many other scholars out there who can go and study something. I'm going to focus on something that I think is really important, like medical errors or mobile health clinics or something like that we need. That's where I feel I can lend my voice. And I think that is somehow translated to my participants, that I really care about what I'm studying. I'm not just like, oh, I'm signing on for this study because I need a publication. I'll sign on to a study if I value and care about the topic and think that I can contribute something and make it better.
Well, and I think that kind of leads to the next question when we talk about challenges associated with continuing our research in the middle of this pandemic. If you don't really care about what you're doing, you're not passionate, it's really hard to find the motivation to keep going. So can you kind of talk about that a little bit, about how it has affected, or maybe it hasn't, but sort of how you're continuing your research in the middle of all this?
Yeah, and it affected me a lot, actually. So last fall, I had just started work with my standardized patient lab, and we had some amazing success in the fall. And so we had piloted our interview protocol And in the spring, we were transitioning to take the protocol and actually go out into the community and start talking with community members, adults, etc. And I guess I should preface this since nobody on the podcast knows what I'm doing. The study that we're doing is about doorknob disclosures, which is such an important communication event and has never been studied by communication scholars. In fact, it also really has not been studied much in the medical field either, but it's this really common communication experience. And so we were just getting started. We, I think, had done 2 interviews, and then COVID happened. And that really, kind of shook me and my lab team kind of for a loop here, because how are we going to recruit people? First, we did have to change our IRB because all of our interviews were supposed to be face-to-face.
Right.
So we had to change the IRB for that. But, how are we going to recruit people and say, hey, can we, call you over the phone and do this interview over the phone? How can we make that connection? Because they're somewhat short interviews, but we're asking people to talk about, doorknob disclosures, from what we can tell, are born from embarrassment and vulnerability and fear. And how do you get people to talk about those things if you're not face to face and you can't communicate that empathy with them? And so that's been a big challenge for us. We did just kind of get back restarted again. We've done 2 or 3, I have to go back and look, 2 or 3 interviews since we got the IRB addendum to do phone interviews. And so that's been a challenge because I think that there's important work to be done here that communication scholars can really make for patients and providers, because neither really know how to deal with them well, that we can train providers to be better about doorknob disclosures and help patients get over some of those fears.
Well, so
have there been
go ahead.
any bright spots from the change in normal work?
I had to make some really tough choices about some work. I don't know if that's a bright spot. I don't know. I don't know there have necessarily been any bright spots, in part because, and not like as in a bad way, just since, as I said before, right, I don't take on work that I'm not like really passionate about. And it's not that I'm not passionate about COVID research, but there are so many wonderful researchers out there doing so many amazing things that I haven't felt the need to dip my toe into that. I don't feel like I would just be another voice amongst all the voices, and I still want to be able to focus my work. So I guess a bright spot is that it has helped me kind of reinforce my research beliefs, and it's allowed me to, I had to make some tough choices about, what can I reasonably get done this next year? What's going to be possible to get done this year?
I think that's a definite bright spot.
It is, right? I am going to see it that way. It's a bright spot because it's so easy to sometimes take on too much. And maybe the bright spot of the pandemic is it's allowed me to step back and say, okay, what's reasonable in the world that we're living in right now?
Definitely.
Sure.
So as we wrap this up, kind of a fun question, and maybe one that will give us a little bit of hope. As academics, we have the good fortune of being able to travel to different countries and different cities. Do you have a favorite place that you've either visited in the past, or a favorite place, or a place that you're kind of excited about in terms of future conferences where you can present your research?
Well, I'm really excited for the 2021 NCA because I love Seattle. I went there. I hope it happens. I went there for the first time last February for Western Communication Association. I'd never been to Seattle, and I absolutely loved it. So I'm really excited to be able to go back there. And then the year after that, NCA is in one of my favorite places, which is New Orleans. So I'm excited to be able to get back to New Orleans. I love it. And the thing is, we're only 4 hours away from New Orleans. We're so close. I just love New Orleans. I love kind of the feel of New Orleans. So I'm excited to be able to get back to that. And just, it's one of my favorite cities. And every time I've been able to go there for a conference, I just am reminded about how much I really enjoy it as a place.
Well, Dr. Heather Carmack, thank you so much for spending your time with us this morning. It's been just a really informative and interesting conversation, and thank you so much.
Thanks for having me.
All right. Bye.
Bye.
Thanks so much for joining us today for our No Stupid Questions podcast. We hope you enjoyed our conversation with Dr. Heather Carmack. And just as a teaser for next week, we're going to be talking with Dr. Andy Billings, who's going to be addressing the way sport communication research can help us identify fault lines in social issues. It is a great conversation. If you have a second, please give us a 5-star rating so that other listeners can find the podcast as well. See you next week.